I guess this question is quite general to the panel. It's surrounding whether they believe there's kind of a stigma around neurology and disability among BAME communities. This is something that we sometimes hear about, kind of facing a stigma within the community, but also outside in terms of kind of racism and ableism.
That's interesting. I think Andrew has probably got some answers to that, but I can answer for the Maori and PI background from the culture, and that is that yes, there is a stigma to having a neurological condition because of the warrior background and warrior mentality. If it's a man, that you've then got a weakness and can't fulfill your role. But that's obviously a very small minority of people. And Andrew, have you got anything?
Yeah, okay. Stigma is a big issue, and it varies for different communities and different sections of different communities. It's such a big issue that quite often people who've got neurological conditions won't want to be discussing that with anybody in their community. They want to keep it away from the community. It can also be a cultural thing about looking after people. See, if you don't understand what a neurological condition is, right, within your culture and your background, quite often what can happen is people can look after their family member for longer than they would if they were familiar with the English way of doing things, if you like. So it can be not so much a stigma, although that is a big issue. In some cases, it's not even so much a stigma. It's just that the community or individuals within the community or the family are looking after somebody and not really thinking of it as a medical condition, thinking of it more as a mental health condition, or maybe just somebody's getting older or something like that, and just not accessing the services as early as they would had they had the full information available to them. But stigma is a massive issue, and it's hard to generalize about it because Chinese community is big stigma, but how that works out is different in many cases than it would be, say, for if you like the Asian community, where there is also a big stigma. But in terms of what actually means for the family or for the individual and how they cope with it will be different. That's why really this is a hard nut to crack, this, because it's so complex. The issues are so complex. And the only way really to do it is to get to know individual communities and what their barriers are. So it's a long, hard slog, but it's definitely worth doing.
Absolutely. Do you think one of the things that we could do, this is putting it out there to people, is perhaps have a champion in each services or in each region, or even within the CCG?
Absolutely.
Yeah.
In communities, absolutely. That's going to be a big thing. Yeah, that's what big part of the solution.
Yeah.
Definitely, if people who are high profile from BAME communities can say, I've got MND or whatever it might be, that changes things.
Absolutely. That's a fantastic idea, actually, a really good suggestion on that one. I noticed that May Lim actually put earlier, working as an occupational therapist, that she's mentioned what you have, Andrew. May Lim, would you like to come in?
Yes, love to. Sorry, I can't find video here. So just picking up on what you're saying, Andrew, I totally agree that so I've been locuming recently, and I've worked in lots of different hospitals in their neuro services, and I've noticed, this is my personal impression, so I don't know if there's evidence out there, and I haven't taken the time to research this as yet. But in terms of my personal impression is that there's a trend of Chinese people, Asian people, Black people kind of holding off from accessing services because A, they don't want to burden the NHS, B, their families take the attitude of, we can look after you, so we can cope with this. And it's only when they get to crisis point that they would actually access services. This is my personal impression, but from working in quite a few hospitals. And then the other thing that I think might be a trend and is worth looking at is because of the stigma and because of the attitudes around neurological conditions. So, and because rehab for neurological conditions hasn't been around that long, I mean, like 20 years, as in really effective, and we've done so much work on how much more effective we can become. So I see a lot of people, because of the general attitudes, giving up earlier, which leads to poorer outcomes, which means that they may not be referred on to onward services after that, because it's kind of seen as that they're not participating in rehab. Those are my personal impressions, but as I say, I would be interested to try and put a study out together to try and see if that's actually verifiable.
I think that's something perhaps, Georgina, we can consider for including in our patient experience survey, more questions along that area, indeed. And that's something that I think all the charities that are represented here today can also look at, just adding more EDI type questions and inquiries to their service on that. So I think we've got the last 5 minutes. We have probably got time for one more question, but what I'd like you to consider really is the ideas, more ideas of how your organisation might need to adapt, so that if you've got any ideas that you want to share, that would be a real useful end to this session. Caroline Morrice, perhaps. Are you still with us?
I am, yes. Sitting quietly. Thank you.
Putting you on the spot there, yes.
Yeah, I was just actually giving it some thought, and based on what Trish sort of said a little while ago about having maybe that need to have translations. It's the understanding of translations was what caught me in what she said, you know, being able to, we could have it written in any language that we chose, but it's actually the understanding of what's being written there. But certainly something that we could look at is translations, if it would make a difference, because I am very conscious, having worked in the charity sector for quite a while now, that we are often seen as being very white middle class, and although we want to reach out to everybody because we want to look after everybody and help everybody, sometimes there's just that misconception, maybe, you know, because of where we're located would affect us, because I being in Lincolnshire, we don't have a very high BAME sort of sector here at all. Probably the east of England would say that, you know, apart from certain big towns. So yes, maybe that's the thing, is to sort of start maybe with some different languages.
Okay. Yeah.
Yes, thank you, Sue. I agree.
Sue, thank you, Sue. Sue stated the obvious. Yeah, yeah.
It's true. Yeah, very true.
It is, which is again why we're looking to do something with our board as well. Although you have got me, yeah, the person with the tan year round.
Can I just interject about translations, please? Yeah. Okay. In terms of translations, it's very important to have that. That is the basics in place. Yeah. But before you actually do it, you've got to really be clear about what you're going to do with your translations. You know, It's no good having really good translated material in, if you like, the equivalent of plain English for each different language. That's what you need as your basics. But then what are you going to do with it? Will it sit there mouldering for years, or are you going to use this information to get out into the community and get the message across? Because the community quite often, you know, it's so hard to generalize, but a bit of a generalization would say that a lot of the smaller communities, word of mouth is the thing. So you get your word of mouth going and you use your translated material to back that up.
Absolutely, I did hear absolutely, and made a note of that. And somebody else has commented earlier that you can have a load of leaflets given you in a GP surgery, or you know, to a ward, to therapy or the specialist nurses, but they might sit on the shelf and mould if the condition is rare, for example. So yeah. So I'm going to try and summarise this really good session. I've really enjoyed listening to the speakers and found it very, very useful, and thank you everybody for your contributions. That's been fantastic. And I think the big things are how we communicate, and not from our privileged position, but actually engaging with people to find out how they want communicating with. It's no good giving a message if it can't be received. So that's one. And I think using localities then, locality introductions, so that the communication gives the control, and I'm all for control back to the people who need to use the service, rather than a service directing how people should access it. I think that's absolutely key to any progress. Otherwise, Andrew, we will continue to slog on for the next 20 years, but thankfully I retire in a year. So that's, and how we work on the translation of our rather complex area of neurology, or those wonderful words that we use, and the description of how it affects people. Any contributions to that would be probably gratefully received. Okay, so over to you, Georgina. That's thank you from me.
No, thank you ever so much, Amanda, for chairing. Thank you ever so much, Trish and Andrew, for your wonderful contributions. And as I said, you know, as an alliance, we're very much committed to kind of exploring some of these issues further and trying to stimulate, I guess, a bit more of a conversation and trying to improve evidence, to be honest with you. So this is the kind of first step really in what I hope is a, you know, a longer kind of journey to address inequity. So if they've got any suggestions or thoughts about how the Alliance could bring people together, or what we could be doing to prompt change in the wider kind of sector, please just get in touch. Hopefully, you know, you've got my email address, but I'll pop it in the chat just in case. Very much committed to all of this, and thank you again.
Thank you very much.